So we have completed inspection. Then the next part is palpation. So after seeing the or observing the patient, we are going to test the patient. When we test the patient, it becomes palpation. So ensure that our palms are warm and should be comfortable to the patient also. So what all things we have to observe or we have to do in palpation is, first of all, we are confirming the findings in inspection. So in palpation, first of all, we are touching the patient. So first thing you have to note is the if there is any variation in the temperature. For example, in inflammatory conditions, there will be a rise in temperature. Then look for pain and tenderness. If the patient is complaining, then we can term it as pain. Then if you are when we palpate, if the patient is feeling pain, then we can term it as tenderness. So look for pain and tenderness. Then we might have noted swellings in inspection. Then we have to palpate that area, and we can do that in local examination also, palpation of individual swellings. So all the parameters we have to note in examination of swelling also. So note the size of the swelling, diameter, shape, then the borders, fixity to the skin, movability, pulsatile or not. All this we have to note in palpation. So that's about swellings. Then the next point is tracheal position. We have noted the position of trachea in inspection. Here we have to palpate the trachea. Palpation of trachea is very simple. I will just demonstrate the palpation of trachea. Index finger and ring finger over these two prominences. That is the sternoclavicular junction. Then place the tip of the finger over the thyroid cartilage like this. Then palpate downwards up to the suprasternal notch. You can feel that notch here. Then you can palpate the tracheal cartilages here. This is the sternocleidomastoid muscle tendon. Then insert pressure over this area on both sides. If it is moving to one side, for example, this is the left side. If my finger is slipping into that area, then we can think that the trachea is shifted towards the right. And if the finger is slipping towards this side, that is the right side, we can infer the trachea is moved or shifted towards the left side. So look for deviation, if any, in palpation. This is the way of palpation. I use these two fingers or keep these fingers here or these prominences, then middle finger over the cartilage, palpate downwards up to suprasternal notch. Okay, this is the palpation of trachea. So next we have to palpate the apex beat. So apex beat position, the normal position is the left fifth intercostal space in the mid clavicular line. Around this area is the apex beat normally. So you have to palpate that area. You can move laterally and towards medially for any palpable pulsations. Palpable pulsations are called thrill. Palpable pulsations can be termed as thrill. So it can happen in murmurs like that, or advanced heart conditions or valvular conditions. You may get vibrations, or this vibration may be transmitted towards our palm, and that can be termed as thrill. So palpate the apex beat, look for a shift and towards the left and axillary border, or towards the right left sternal border. Look for shift and also for thrill. So that's about palpation of apex beat. For the next thing we have to do in palpation is examination of or noting the chest expansion. That's a very important test. It's a symbol of health. So chest expansion examination is also very important in the respiratory health also. So for that we have to use a Taylor's step. Keep the zero marking in the central area. Then ask the patient to expire maximum. Please expire. See, it's 78 centimeter. It should be at around about the level of nipples. The tape should be placed horizontally and should be about the level of nipples and approximately. Then note the zero mark in centimeters after asking the patient to expire maximum. Please expire maximum. It's around 78. Inspire maximum. See the difference, it's around 84. So the difference is about 5 centimeter. So that's the way of doing chest expansion. So the chest expansion in this case is around 5 centimeter. The importance is that the normal chest expansion in a male person is around 4 to 5 centimeter. In a female person, it is a bit less, around 4 centimeter. Then the chest expansion may be increased in athletes. It's a good sign. It is considered as a good thing in health as far as health is concerned. But the importance is that if the chest expansion is decreased, or maybe it can reach to 1 centimeter or hardly 1 centimeter, it can happen in two conditions. The chest expansion may be diminished in emphysema, condition called emphysema, where the chest is in an already hyperinflated state. So when we do chest expansion, the difference will be very less, or it will be below 1 centimeter. The same thing can happen, or the chest expansion may be diminished, or hardly one can happen, may diminish to 1 centimeter in pulmonary fibrosis also. There is restriction of movement. It happens due to restriction of chest movement. So two conditions that can lead to diminution of chest expansion is emphysema and pulmonary fibrosis. So that's about chest expansion. Then the next thing we have to note is symmetry of chest. Symmetry of chest we have to do in palpation. So in inspection we have observed if there is any visible change in the movement of chest, it comes under symmetry. So in palpation we are confirming it. So I will show the method of examining the symmetry of chest. So we are doing the symmetry of chest. For that we have to use the both hands. Keep it like this at this level, around about the level of nipples. Place the or oppose the both thumbs in this area or in the mid area. Then hold the chest like this, not too tight or not too loose. Then ask the patient to expire maximum. Then inspire max. Expire. See the movement of thumb. You can see the movement of hand like this. So the hands are moving, both hands are moving symmetrically, then the movement is symmetrical. The both lungs are normal in this case. If a hand is stationary, then we can infer that that part is affected, or it is pathological. So whatever the pathology, the affected area move less. That is the principle. Whatever the pathology, the affected area move less. So that's about the symmetry. Last part in palpation is tactile vocal fremitus. Same thing we have to do in auscultation also. When then the test is almost symmetrical, identical. Here we are using our both hands. In auscultation we are using the step. The procedure is the same. So here we are asking the patient to say resonating words. For example, 1, 1, 1 or 9, 9 or 99, 99 in a moderately louder voice. Then we are palpating with our both hands. So please say
1, 1, 1, 1, 1, 1, 1, 1, and 1, 1, 1.
So this is the way of palpation. We have to use our both hands and we have to examine identical areas at a time, like this. So here we are feeling the vibration. The sound is produced in the vocal cords or the laryngeal area, then transmitted downwards, then it is attenuated and transmitted outwards towards the outer layer or towards the skin, and we are feeling the vibration. So the sound conduction is judged. So the principle is that the sound is conducted more by solids and least by air, when the medium is air. So when there is a pathology involving the lungs, for example, there is in consolidation or in lobar pneumonia, the lungs get solidified, so the sound gets easily transmitted towards to the outside. So we can very well feel the vibration. So we can say the vocal resonance or the vibration is vocal frequency is increased. So on the contrary, in case of emphysema, there is air collection, excessive air collection, or there is dilatation of airways, or in pneumothorax, when there is collection of air in the pleural cavity, the sound is conducted minimum, or the tactile vocal frequency is reduced. So this is the principle of behind doing tactile vocal frequency or doing vocal resonance. So when we use both hands, we can term it as tactile vocal frequency. In auscultation, the same procedure is there, then we can term it as vocal resonance. Okay, that's about tactile vocal frequency. So that's about palpation. So I will repeat the points coming under palpation are: chest palpation are temperature, you have to note the temperature, then look for pain and tenderness, then examination of swellings if any, then position of trachea, then position of apex beat, then this chest expansion, then symmetry of chest, and finally tactile vocal frequency. So thank you, that's about palpation. Then we can move on to percussion.